Hi, everyone, and welcome to this edition of the Global PAD Impact Awards. It is my great pleasure to announce the recipient of the 2024 Global Limb Salvage Team of the Year Award, presented by the Global PAD Association. This prestigious honor recognizes a multidisciplinary team that has demonstrated exceptional dedication and innovation in providing advanced life and limb-saving care to patients with peripheral artery disease around the world. This year's award goes to the outstanding team at the Cardiovascular Institute of the South, led by their visionary founder, Dr. Craig Walker. Since its inception in 1983, this institute has been pushing the boundaries of what's possible in the treatment of peripheral artery disease. They have been at the forefront of cardiovascular and vascular care, pioneering numerous firsts in the field and earning international acclaim for their research and development efforts. But they're not just about cutting-edge procedures. They've created a holistic approach that's second to none. Their team of physicians and clinicians work collaboratively to provide comprehensive treatment, from innovative approaches to patient education and lifestyle modification support. They go above and beyond to prevent patients from falling through the cracks, providing exceptional aftercare and support throughout their entire journey. Their efforts, with a commitment to better patient outcomes, have contributed significantly to improving the lives of those affected by PAD and have helped to advance the standards of care in the entire field. Dr. Walker and his team have not only made a substantial impact locally in Louisiana and Mississippi, but have also extended their reach globally through educational programs such as the annual New Cardiovascular Horizons Conference that is 25 years and still going strong. So the Cardiovascular Institute of the South's commitment to innovation, patient care, and education truly embodies the spirit of this award. Their work has not only saved countless limbs, but has also significantly improved the quality of life for PAD patients across the globe. That's why I'm pleased to announce that the Cardiovascular Institute of the South has earned the prestigious 2024 Global Limb Salvage Team of the Year Award. And to receive the award, we have incredible visionary and founder, Dr. Craig Walker.
Thank you very much, Kimberly. That's a real honor. And I know you know this is a passion, not just of me, but of our whole team. We have an exceptional group of people. Back when I started Cardiovascular Institute of the South, now 41 years ago, I was a pretty young guy at that time. And the first thing I did was I wrote a mission statement. What did I want for my community? Because I was leaving Boston and a great training program to move back to my hometown, where there was no cath lab, there was no CCU, there was no equipment for cardiac work. But I thought the very first thing I wanted to do was to write a mission statement. Throughout my life, when I was studying for school and other things, I always wrote what I wanted to accomplish. I wrote down my goals, short-term, medium, and long-term goals. But in addition to that, in founding this company, I was dreaming, what did I want to become as a company? It was just me when I started, yet I wrote a very, very extensive mission statement. I'll walk you in the hall and show you. This stands in every one of our offices. And if we could, we'll walk out in the office and I'll show you the mission statement. I'll get a little clearer copy for people to work. But this is in every examination room, the mission statement that you see here. And I know this is not so clear here, but I will bring it up in a better image. But in every examination room, in every waiting room, in every hall of CIS, that mission statement sits there. When we interview every doctor that we've ever interviewed, and now we've gotten up to 86 cardiologists, we've interviewed these, and all of them, we read this mission statement. And we check to make sure that they feel that it is an appropriate mission statement for them and that it is what they're hoping to accomplish. And, you know, that has let me get some unbelievably great partners. My partners are doing live cases around the world. They are great friends as well. And we have developed a team here that allows us to work with everybody. We've worked with the surgeons, we've worked with the podiatrists, the neurologists, the infectious disease people. And that's really what it takes to better treat patients. Yet that's all too often overlooked or simply lost with some of the fighting that goes on in today's world. We have an epidemic of cardiovascular disorders, heart disease, of course, and it's on the rise again, but peripheral vascular disease. And as you know, I really feel peripheral vascular disease has not been given its proper place. It is a killer. It accounts for more deaths in women than breast cancer by far, not even close. It's a killer in men. We know that someone with a new diagnosis of peripheral artery disease has about a 20% event rate that year. And all this is preventable if we make the diagnosis and start therapies.
As a pioneer in peripheral vascular disease treatment, what really inspired your focus on limb salvage and amputation prevention? Because we can certainly tell you have a very powerful passion for limb salvage.
I am really passionate about this. I have had many epiphany moments in my career, epiphany moments where I saw things that I did not expect, things that I sort of did expect, but wasn't able to handle. So one of my first epiphany moments was I did an intervention as a fellow. I'd already had full training in angioplasty. By default, I was one of the first angioplasty fellows in the United States. And I recognized as we were going up the patient's leg to place an intra-aortic balloon pump in a patient who had presented having a heart attack, that there was disease involving the iliac arteries. Nonetheless, we had to place an intra-aortic balloon pump to save the patient's life. Well, we did save that patient's life. We were able to do an urgent angioplasty. He was a young man, but in the process of this, saving his life, we lost his leg. And we lost his leg because I could not intervene on his iliac artery, which I was very clear in my understanding that he had the disease because I could see the wires that bounced off a lesion as I was going up. Now, at that moment, we clearly had to save his life. We had no other choice, but I thought at that moment, it made no sense that I could not intervene on that iliac artery, which would have taken me a minute. And I could have still saved this life and not lost a leg. And at that point, I decided I needed to learn peripheral artery disease. I needed to be able to treat it. I recognized that it would get in the way of many of my heart treatments. And so that's really kind of where I started, was I was viewing it as allowing me to be able to do more things to help people with heart disease. But the more I became involved, the more I realized what a killer it is, the more I realized how prevalent it is, and the more I realized how it's poorly treated across America. Historically, people look at peripheral artery disease as simply a disease of the leg. It is not that. It is a systemic disease. People with peripheral artery disease have a much higher incidence of dying of a heart attack than a heart attack survivor. These people are sick, and I tell people all the time, sick legs are almost never attached to healthy people. Well, that was certainly an epiphany moment. And then I started to follow that mantra of sick legs not being attached to healthy people. And so I religiously checked peripheral pulses in patients. Now, you must understand, a lot of people never complain about their peripheral artery disease. They think they're either just getting old, or that they have arthritic pains, or that it's their back. I can't tell you how many people have been scheduled for back surgery or leg surgery who had blocked arteries that once we fixed them, of course, those pains went away. But I recognized it was absolutely crucial to make that diagnosis, because then we've identified a high-risk patient. Then we know to look for their potential heart disease, to look for their potential carotid disease, to make sure that they quit smoking, to lower their cholesterol, to control their diabetes, to start a walking program, perhaps to start an antiplatelet agent. And I recognized that in our community, that this was saving lives. I saw it so many cases where I didn't feel a pulse. I found critical disease. We were able to treat that. I found many people who had advanced disease, not yet critical, who were able to start preventive measures. And then the next thing that became incredibly obvious to me, this disease was far more prevalent in minorities. So I reached out in our community to minorities and the elderly who maybe didn't understand this. I was a regular speaker at the Council of Aging. I went into Indian tribal homes. We have a very large African American community here. I went into Black churches and other things, and I proactively sought out those groups who have a higher incidence of amputation, who have a higher incidence of death from this problem, and proactively told them about this. And proof of that is now in the pudding. When Medicare showed their rates of intervention before any consideration of amputation and showed the rates of amputation, CIS was a shining star. Okay, we had within our region dropped amputations dramatically, dropped mortality dramatically, and with that had lessened healthcare costs. Because amputations, many people think it's a simple thing. You just cut the leg off, but they're far more expensive than performing limb salvage. And yet we have really, really poor definitions of things. People were historically called overly ambitious if they even did an angiogram, or overly aggressive, but not aggressive at all if they simply cut a leg off. Well, that's crazy noise. The risk of doing an angiogram in today's world is far less than 1 in 1,000 death rates. Whereas the rate of death from an amputation in the best centers in the world for atherosclerotic disease is about a 30-day mortality of 5 to 8% if it's a below the knee, and 8 to 12% if it's an above the knee amputation. A third of those patients go to nursing homes and never leave again. These aren't young soldiers with a traumatic amputation that we see in the Paralympics. These are old, infirmed people. And I realized that our definitions were wrong, our concept of treatment was wrong, and that we could do better. And we had developed a very advanced wire skill set, for sure, but we didn't know all of the nuances of peripheral artery disease. We brought in vascular surgeons. We worked with those guys closely. We could help teach them wire skills. They could teach us more about the anatomy and physiology. We worked with interventional radiologists to further hone the skills. And all of us together were able to achieve a lot. All of us noted that our practices got better, got stronger, got busier, because the big problem that's occurring right now in the United States with peripheral artery disease is we have an epidemic and we have people fighting instead of treating the problem. And it really bothers me. It's something that I spend a lot of time fighting. In fact, I was just at a conference. My community had just been hit, in fact, was going to be hit the day I left, by a hurricane coming immediately up the parish in which I live. A parish is like a county everywhere else, but in Louisiana, we call them parishes. And this hurricane was coming in. My family evacuated. I had to drive all the way to Florida, about a 4.5-hour drive, to catch an airplane to go up and speak on this subject. But I wanted to do that because I think it's so important we spread the message. We have developed over the years much better therapies for peripheral artery disease and for saving legs. Some of those therapies are surgery. Some of those are interventional. Some of those are even just medicinal. But I really think that we're on the precipice of being able to avoid most ischemic amputations, particularly if we can get to the patients earlier. And yet we have no awareness. While I was preparing my lectures and sitting in the hotel room in New Jersey, I saw 3 ads from the Komen Foundation about breast cancer in women. 3. I never hear anything about peripheral artery disease like that, yet this kills far more women than breast cancer. And I'm not suggesting that we should ignore their efforts in breast cancer. I think they're spectacular. I think we should do the same for peripheral disease. And I think we can do it. We should do it. And people say, well, Craig, if a patient's not having terrible pain and there's no tissue loss, why do you want to make the diagnosis? And I said, it's real simple. It's something that the Chinese philosopher Hu Dinao Chang many, many, many centuries ago said, that the inferior doctor treats actual sickness, the mediocre doctor attends to severe sickness, while the superior doctor prevents illness. If we can get to patients early, we can stop the ischemic cascade. We can put these patients on better diets, exercise programs, smoking cessation. And if we're able to screen and see that the pressure in their legs is lower than the pressure in their arms, which it should not be, it should be the same, or slightly higher, actually, based on something we call Fournier's waveform analysis, but it should not be lower, then that person has peripheral artery disease. And when I see a patient with that finding, I tell them, you have a real problem. You have a blockage in the arteries of your legs, but people with blockages in the arteries of the legs often have blockages elsewhere. It's the same process. And so if we can shut that process down now, while you're relatively asymptomatic, it may never manifest itself in a bad way. If we can start a walking program now, we can help your body create new bypass vessels in this area. So I think making the diagnosis is crucial, yet many in my field see no importance at all about making the diagnosis unless someone's leg is ready to fall off. And I think this is a huge error that we're making. Again, it would be akin to waiting to make the diagnosis of breast cancer when it has metastasized throughout the body. That is an error. That's not when one should be making the diagnosis. One wants to make the diagnosis at the earliest possible stage. So some of the limb salvage colleagues really view this as cancer in a sense. It's not a cancer in that it's uncontrolled growth, but it has the same ultimate consequences. And the sooner we get to it, the more effectively we treat it. The basic premise of medicine, and I'm a high-level interventionist. I get people sent to me from all over the world for limb salvage, but I'll be the first to tell you, prevention is better than that. If we can prevent the disease, much better. But if we have to treat that end-stage disease, we can do that now too. We can do it effectively. And all too often, patients are not given that as an option. And that bothers me.
I completely agree. I think in terms of the prevention and getting the word out there, I think that we need a more collaborative approach, with all hands on deck versus every single organization trying to own the patients and take the credit and have the website to their own with just a few other names on it. But everyone needs to come together and say, let's collectively put our money in the hat and let's create the most groundbreaking pad awareness campaign imaginable. And I think that that's what happened with breast cancer. And that's why the word got out there. Not only the word got out there, but they created this groundswell of patients going to their doctor and saying, hey, I expect more out of you. You need to get me that test. And that's what we need with our patients. And that's what we're even hoping to do with our 12,000 patients around the world is saying, hey, go to your primary care, go to your GP and say, I deserve to have an ABI test. I have the risk factors. Please test me now.
Kim, almost every day of my career, I see patients who are coming to me for limb salvage who have had a major amputation and their other leg is now in trouble. And, almost across the board, all of those patients told me, Doc, I had no idea what the amputation would have meant to me because they thought first the pain would go away. Well, phantom limb pain continues. They thought that this was going to be one and done. Often they needed revisions of the amputations. And so I don't think we're always 100% honest in telling, people about this problem. And certainly intervention, if it has a negative, it's that sometimes it must be repeated. And that I'm hoping we can get away from. But I must tell you, in today's world, it's so much better than it was before. We can cross better. We now have drug-eluting balloons. We have balloons that deliver medicines. We have stents that deliver medicines. We've got superior design stents. We've got cryo balloons. And so the results are getting better and better and better and more durable. And I can't tell you how many people I've done limb salvage who had one procedure and were done and have gone on to have 20 more years with their legs. And if I show you some of these cases, you will go, no way, that leg is unsalvageable. But these were tough cases in certain circumstances. But I also have to tell you, I see patients who often have easy fixes, who are told their only option is amputation. We have to stop that.
And 35% of those that have called our Lifesaver hotline, out of the 1,000 limbs that we have tangibly saved, they weren't even diagnosed with peripheral artery disease prior to being on deck for amputation. It wasn't until calling our Lifesaver hotline and us saying, hey, you need to ask your doctor for a vascular evaluation first, that they discovered that they had a circulation issue, that it wasn't just diabetes, it was something called peripheral artery disease, and that something could in fact be done if they got a second opinion.
In fact,
and that's really disconcerting.
For sure. Well,
these doctors need to stop giving up on the patient and start giving up the patient.
Sure. Well, we always talk about diabetic foot disease, and there is a lot of forms of diabetic foot disease, one of which is when you lose sensation and therefore you end up with some bony destruction, what we call Charcot's foot. But a lot of diabetic foot disease is actually vascular in cause. And so many people say, well, it's just maybe the nerves are bad and that's what's going on. But that's actually the minority of cases. Most of these people have concomitant significant arterial blockages. And so this is very important, and getting back to the disciplines working together, each discipline brings a certain level of expertise. And that's why we put these disciplines together early on. And no one discipline has given us all of the treatments that we have. In fact, each of the disciplines I mentioned before, interventional cardiology, radiology, surgery, podiatry, wound healing experts, the list goes on. Each of those areas have contributed mightily to limb salvage. And I really believe that we're on the precipice of being able to treat almost everyone at this point, particularly with new techniques such as deep venous arterialization, where even when every vessel, down to the minute vessels of the legs, the minute arteries of the legs, are severely diseased, we now can convert one of the paired tibial veins that go to the foot, convert it into an artery by making a channel from an artery into that vessel. This is called deep venous arterialization. And in that group of people who were originally thought to have no hope, no chance, already limb salvage rates of better than 60% are occurring. And I think we'll get better as we learn more about that technique. So this is a field which has evolved tremendously. I would say, though, however, that the treatment has evolved faster than the capacity to diagnose and refer has evolved. And there are many reasons for that. One reason is there aren't enough doctors right now trained in this, to really reach out and treat all of the patients. Secondly, there are wars going on sometimes between the different disciplines. I don't understand it. It is not as though there's a shortage of patients, not at all. And patients are suffering with this. And I think it is very important for groups to work together. And that's been a theme of my practice for years and years. And I do go to the surgical meetings. I do go to the radiology meetings. I speak at those meetings. And sometimes I go into a hostile crowd, but usually that works out very well. Okay. And I think it's what we have to do. We cannot remain silent on what has to happen for this disease process. And, I would just suggest to people that anytime a boat moves, it makes a wave. But boats are not made to simply sit in the harbor. And doctors are not made to not make a wave. That their purpose is to treat patients. And whenever we speak about changing the way patients are treated, that causes angst because people are used to doing something in one way. I've never been quite bitten by that bug because I've always believed the philosophy my father had told me. And he said, Craig, change is not always better. In fact, change is sometimes really bad, but you can never get better without change. And I think that's a very important guiding light. And we do have to change when we see things that are tangible and good. And that can help us. And that's what I'm hoping we can achieve with the outreach that we've done. And, recently, I think we've had some setbacks in terms of patient care. I'm sorry this has happened. I hate seeing this. But even at this meeting, I saw doctors coming together, speaking, this is right, and bonding on the things that we have in common rather than fighting over which discipline should do this or other things. It makes no sense to me and never has, and I doubt if it ever will. I think that our first contract is not to a discipline, but to our patient. And I think we owe it to each of those patients to do the best we can do.
Yeah, no, I agree. You've been doing really groundbreaking work in limb salvage, but new approaches, they do face scrutiny. Can you just talk about a particular instance where you had to defend your methods or results? How
Sure.
did this experience shape your, future efforts?
I have a talk on what people have told me over the years, and I'll tell you some of the points. I don't have them written down, but I think I can remember most of them. Early on and these were told to me by people who I had great respect for and still have great admiration because in their fields they were spectacular. But I had a very famous cardiothoracic surgeon tell me angioplasty just doesn't work. It's foolish to think you could blow a balloon up in an artery and it might ever stay open. Anyone doing this clearly cannot understand plaque. Well, in some cases, it would come back, but many patients were cured. In fact, some of the very earliest angioplasty patients are still open. Nonetheless, this was a visionary surgeon who was clearly one of the best bypass surgeons I'd ever seen. Yet, that was his comment. I was thinking, I thought that was a bit short-sighted. I've heard people say, well, atherectomy is just inferior endarterectomy. Is that true? Well, endarterectomy requires a big incision. There's a chance for nerve damage, a chance for infection. They're different. And I think there are roles for each. It's fairly interesting. I've heard people say you should never, ever, ever put a stent in an iliac artery. That would be malpractice. That's done every day of the week now. Okay, and I was one of those original stent investigators. Now, you might say, who had made that statement? Well, it was actually published in the surgical and the radiological journals that we should never stent in iliac. Now, of course, that is the standard of care. That is what is considered, the best treatment. It was at one point considered malpractice if you intervened below the hip. The word used in medicine was the inguinal ligament, but in plain terms, that means below the hip. Well, now, of course, that is commonplace. That's interventions there are common. Then you should never intervene behind the knee. You should never intervene below the knee. You should never intervene underneath the foot. The list goes on and on and on and on and on. All of those things became real. Perhaps one of the moments that I was most disappointed, I had started using a technique where when we could not cross total blockages in a patient who was going to lose their leg otherwise, I started sticking the vessels of the foot and you coming with a wire backwards, a pedal approach, so that we could cross the lesions. And with that, we had more than 90% success in people who we'd failed totally coming from above. And I submitted that to a major journal. I actually had as big a series as the rest of the world combined at that time. And instead of publishing this, they sent me back a scathing letter telling me only a fool would ever do this. And I said, but you were going to cut these legs off. And we saved the legs. No comment back. So I think it is important to understand people are scared by new things. They really are. They're frightened by new things. And we have to be able to approach and keep appealing. That didn't slow me down at all, nor did it stop me from going to their meetings in showing them these cases, nor did it stop me from making the point that you may say this is crazy, but this patient saved his leg and you were going to cut it off. And guess what a lot of those people started doing? They started doing pedal sticks. And now, of course, many of those same people who had rejected that are using that commonly. So, I think I have thick skin as long as I'm convinced in my heart and soul I'm doing the right thing for the right reason. And that's what I need. And that's, I think, what helps to advance medicine. But I think you have to have a certain level of conviction. And I think a lot of progress in medicine has not been made because people are so worried about rocking the boat that they're willing to not try something that could be life or limb saving. And I think, again, I would love to see us change in that philosophy.
But I think it's one thing for a physician to argue for their own limitations, but it's another thing to go and use the media and to continue to not only argue for your own limitations, but to get others to do the same and get the media to do your dirty work. And that's really what we're seeing in general these days, with the media often focusing on a handful of doctors allegedly performing unnecessary procedures, which they claim have led to amputations. And this narrative seems to have overshadowed a larger, more critical issue of doctors performing too few procedures, if any at all, before resorting to amputation, right? How do we reconcile this paradox in the current fight to save life and limb? Because it just appears to defy logic, yet it's shaping public perception, driving insurance denials, and even leading some hospitals to ban certain devices altogether. You mentioned atherectomy. So what are your thoughts on this disconnect between this media portrayal and then the reality that you see in your practice?
Yeah, I'm very disappointed by what happened there. I was not part or parcel of any of that, but I think your point is very well taken. We have reams of data that an intervention in someone who has critical limb ischemia saves limbs.
Mhm.
We have reams of data that it saves lives. And in many of those cases, atherectomy is very appropriate. It was almost stated there that atherectomy was a 4-letter word. Okay, of course, it has a lot more letters than 4, but you understand what I'm saying. Atherectomy is an FDA-approved device that has gone through great scrutiny. Now, there is one randomized controlled trial with atherectomy, laser for in-stent restenosis, and it showed that you absolutely should use laser performing atherectomy before if you have in-stent restenosis. And if you didn't, you were subjecting a patient to a higher rate of complications and a less effective outcome. So there is randomized controlled data there. But with some of the other devices, there is a lot of data talking about better limb salvage, better life expectancy, lower cost of interventions, less likelihood of requiring repeat interventions with atherectomy. Yet there are some who say, well, you don't have a randomized controlled trial on that. I think that's somewhat disingenuous. The reason I think it's somewhat disingenuous, I don't think atherectomy should be done on everybody, not at all. But it is unrealistic to expect if one has a totally occluded vessel that's totally occluded for several feet, that just blowing up a balloon is ever going to open that vessel up effectively through its entire course with a good long-term outcome. Practical sense tells us that. Now, I will tell you, and I say this all the time, we have no randomized controlled trials that parachutes work. But how would you ever get someone to be the control group? The group that would jump out of the plane with no parachute. No one would volunteer for that side. No one would sign up for that study. And herein lies the problem. A lot of patients don't want to sign up for a study with something they know effectively doesn't work. A long lesion that's 100% occluded. Balloon angioplasty just doesn't work that well. So I do think it's somewhat disingenuous to make some of the comments that have been made historically. What bothered me profoundly with some of the news articles was it was totally one-sided. There was no chance for rebuttal. For instance, we don't know if the leg amputated was even the same legs that the doctors intervened upon. I asked the person who wrote that article if they knew that, and they said, well, the Medicare database was not that specific. I said, well, I intervene on a lot of people for limb salvage who've already lost their other leg. Should I be accused of making that patient lose his leg if he'd already lost the other leg? I think there's so many things that were not apparent in that, and it's sensational. And I think sensational things are often very bothersome. I remember when there was an older Dr. Gott who came out and talked about how evil beta blockers were. Well, that weekend, I happened to be on call at a major hospital, and patients were coming in with heart attacks because they simply stopped their beta blockers. It's irresponsible. It's irresponsible to make statements like that and to not explain those statements. And I think it was irresponsible of the New York Times to make some of the statements that they made. Now, I do not believe atherectomy is indicated in every case. I don't believe that there's anything that is always indicated. I believe wholeheartedly that every single patient approach has to be individualized. A physician has to use his experience, his common sense, and guidelines based upon what trials did show in these cases to get the best outcomes. And I'm fearful that many people are scared to use products that in their hearts and souls they know are better for fear of criticism. That's a problem. In my opinion, it is a huge problem. There's a secondary problem here that I'm worried about, and that is patients losing trust in physicians in general. I must tell you, I've worked with a lot of doctors over the years, and I think doctors are very concerned about how their patients do. I can tell you, if I have a bad outcome with a patient, I don't sleep well. I remember that. It is a big thing. It is an emotional thing, and I think that's true for most doctors. We went into med school. We could have gone to finance. We could have gone into other things because to get into med school, you had to be a pretty good student and work pretty hard. And I think doctors really work pretty hard to try to get patients the best results they can. And I think there's this constant effort, often by the press, sometimes by trial lawyers, to get rid of that trust that has developed with doctors. By and large, I must tell you, I think doctors do try to do the right things for their patients. Do they sometimes have complications? Yes. Does anyone on the planet always get the outcomes that they're shooting for? Never. Not just as doctors, as lawyers, as teachers, as any profession in the world, because we're not infallible. And we don't have absolute knowledge. And there's a bigger problem than that. The reason that we don't have randomized controlled trials on every form of atherectomy, and this was never spoken of in the press, is because to have a really good randomized controlled trial, one has to control the number of variables. If you have a whole lot of variables, they may negate the ultimate outcomes. For instance, let's just take peripheral disease. What if you're on dialysis and going from having too much fluid in your body to too little after every dialysis session? What if the lesion is 5 times longer than another lesion? What if it's very calcified? What if that patient is prone to thrombosis because of hormonal issues or simply other issues that they may have that make you more prone to thrombosis? What if that patient will continue to smoke? What if that patient doesn't take their medicines, their other medicines? What if the patient's vessels are much smaller? What if the patient's vessels are much larger? What if the patient's vessels are winding? What if the patient has poor runoff to the foot? What if the patient is immobile? The list of variables is so many that by the end of the day, one cannot get a good randomized controlled trial. That's why we have a randomized controlled trial with in-stent restenosis. We've controlled the variable. It's one problem. It is in-stent, and there's a finite lesion, and we can adjust that by the length and the size of the vessel. Now we're at 3 variables. But when we have hundreds of variables in native vessel disease, it is virtually impossible to do a randomized controlled trial and really get meaningful data.
I completely agree. And it's so interesting. I hear it all the time that there's not enough evidence to do this procedure, that procedure, to use this device or that device. And my response is, well, aren't you in the business of practicing medicine? That's what you do. You practice medicine. So why don't you practice medicine and help create the evidence either way? And this is something why CIS again has been named as the Global Limb Salvage Team of the Year for 2024, because it's really been at the forefront of clinical research and development of new interventional technologies that improve patient outcomes and continue to advance care further. And I would love for you to highlight a breakthrough that you and your team are particularly proud of.
Breakthroughs that we have now, of course, we were original stent investigators when the very first stents came out for a heart disease and for peripheral vascular disease. Some of the first to ever put a stent in a patient actively having a heart attack. That was very common. In the peripheral space, we were first-tier investigators of the iliac stent, one of the groundbreaking things. We've now investigated almost every atherectomy tool, almost every stent. We placed the first in man Supera stents, which were developed to be able to treat blockages behind the knee and others. We participated in new trials looking at drug bioabsorbable stents that we place. They work for a while and they ultimately go away. And we think these things are promising. And we're working with other concepts right now, concepts of that are not yet approved, but we're doing animal research with things like amniotic membrane covered stents, using biological tissues to lessen the likelihood of problems. Will those work? We don't know yet, but we're looking. Until we have cured this problem, until we've solved all of the problems, we have to keep looking. And that's how things come about. I can tell you, when I first started doing peripheral intervention, our tools were very few. We didn't even have sheaths right at first, but then we got sheaths. We certainly had no sheaths that could go up and over from one leg to the other. We had really just a couple wires, and they couldn't do any of the things that our present wires can do. We had no stents. We had no atherectomy. We had no laser. We had no shockwave type balloons. You know, for a young physician in today's world, we have so many treatment tools, and yet we have to learn where to use them best. You know, we speak of medicine purely as a science. It is not, and it never was. It is also an art. Now, you know, there is no one on the planet that thinks every singer is the same. There's no one that thinks every football player is the same. But somehow or another in medicine, people believe every doctor is exactly the same. And, you know, each doctor has certain skill sets, certain things, and hence it is also an art. He must use his skill sets, things that he learns, science skills that he learns, but he must practice the art of medicine, the art of in his hands. How does he or she get the best result for their patient? And really, as I train fellows, as I work with others, I have the conversation all the time. I said that you're in a marathon, not a sprint. You are in a lifetime of treating patients. Get to know the patients, work with them, communicate with them, and this will be the most rewarding field that you could ever go into. And I really think right now, people ask me, they say, Craig, we've got all these problems, insurance denials, all these other things. Would you do medicine again? I said, absolutely. They've asked me many times, when are you going to retire? And I said, I've never thought of it. That's absolutely the truth. Because I think it is a wonderful profession. I think it gives us an opportunity to work with people. And I must tell you, some of my patients have become my very closest friends, people we followed over time. They understand what we've done. I have learned so much from patients. I've had patients who've pushed me to do things that I thought we might not be able to help. And I've told them that up front. I said, Doc, please try. And some of these patients led me to learn stenting of celiac arteries and superior mesenteric arteries. Some of these patients pushed me to do limb salvage procedures where I thought it may not help, and by standard teachings, it shouldn't. Some of those patients are now 14 or 15 years out and still have their limbs. And so the communication here is likewise very important. We have to communicate back and forth with patients, and we have to do what they want. I'll never forget, there was a case that I was so disappointed. I was a very young doctor out. We had built a practice in another community in Louisiana, and my doctor that was working there saw a man who had lung cancer, and he had developed some gangrenous skin changes of his toes. And there was a surgeon there who had told him he needed a major amputation. And so this man went to see my cardiologist in the town, and he says, look, do you think you can help this leg? And he says, I don't know. He says, but I have a partner that does a lot of leg work. I would like you to maybe see him, and maybe he could give you better answers. So I went there and I saw this man, and I didn't think I would be able to help him, to be completely honest. I told him that. I said, with the tools, this is before we had crossover sheaths, before we had other things, we didn't have a lot of tools to stabilize the leg. He had a very long SFA occlusion. And I said, I just don't think I can. He says, would you please? I said, well, there's a chance I could hurt you. He says, Doc, I honestly would prefer dying than losing my leg. He says, I've got cancer. I know I'm going to die, but my leg hurts. Would you please try? And I thought about that. And I said, okay, I will try. Well, long and the short, this was an easy procedure. We were successful. At the end of this procedure, this patient had a booming pulse in his foot, easy pulse to feel. You go there, and I was frankly very surprised. That surgeon rushed into this man's room and told him, how dare he not follow his instructions when he told him what to do. This man died 2 years later and still had his leg. He had never had another recurrent problem. I was reported to the ethics commission by this physician, and I had to go there and defend myself for having done what a patient wanted, for getting a great result that the patient was very pleased with, because this doctor's ego was hurt. I find that shameful. And I think there was clearly an ethics violation. I just don't think I was the one making that ethics violation. And that's what I told the board. And I told them that I thought it was absolutely ridiculous that they had called me in for a good result, that perhaps if this man had lost his leg as I did this, even though I was doing what he was asking for, that maybe I could understand this, but how could they do this when the man had exactly the result that he wanted, that I wanted, that he had begged for at that moment? And so that kind of nonsense goes on. Now, much of that we've gotten over in the decades that have passed, because more and more people have accepted intervention and its care. And by the way, I work with surgeons. I send cases to surgeons. I think if one has a very, very long total blockage and has good targets, I think surgery is very helpful. I don't understand the battles going on. I don't. I clearly didn't understand when this doctor did this. And I actually had a conversation with him, and I told him I was disappointed in him as a human being and as a doctor. And he didn't like that very much, but I thought it was appropriate for me to tell him that.
So interesting. You've trained more than 1,000 physicians in peripheral vascular procedures, personally, but then the thousands and thousands and thousands of more globally, including in China, but, most importantly at NCVH, the New Cardiovascular Horizons Conference, 25 years and still going strong every single year. What do you think the most important lesson is that you teach each and every one? What is the most important message? Because obviously you can't give heart to people. And obviously, based on the story that you just shared, that's above and beyond, in so many cases, the call of duty, right? That some would say. And that involves so much more than just what's in a textbook or part of your degree. It's part of who you are at your core. How
Sure.
do you teach that?
Sure. Well, you've seen now my mission statement and what we're speaking about. And part of our mission statement is education, first of ourselves and then of others. Communication, that's not just with patients, that's with doctors, with other people. And really, it's been a big effort. I've really traveled the world doing this. Japan, I've trained many of the sensei there in the past, and certainly in China, I've gone around parts of Europe as well, and many places in the United States, performing hands-on courses and things that we did to help train people in how to help patients.
Mhm.
A lot of these people have become really quite famous and have done, fantastic work. I couldn't be more proud of these people. And Kim, it's never hurt my practice. I've trained people in my own town who are, quote, competitors. It's never hurt my practice because I think this disease is so prevalent,
Yep.
so deadly, so disabling that if we had 5 times more doctors treating it than we do now, we still couldn't treat all of the patients who have this problem. So I don't understand the fights that still go on, and nor do I understand people's inability to park their egos at the door. There are many things that I don't do in limb salvage work. I've had one of my young doctors take on deep venous arterialization. Others take on other certain issues. And why do I do that? Well, number one, I believe you can't be the best in everything. You have to really concentrate on certain areas. Secondly, in my heart and soul, I believe that it's far better for one doctor to do 100 of something new procedures than 100 doctors each do one. And so we've tried to take this team concept and say, let's all be part of a team. Let's create, the best possible approach. And I will often tell one of my patients, I've got a guy who is doing this. He's done a lot of them. He can do this probably better than I could do it. And so I want you to go there. Again, we have a problem throughout our world. In fact, not just here, with people, beating their chest and wanting to be that guy. I think that's losing track of reality, to be completely honest. None of us can do everything the best. I like to swim, but I would sure hate to have to swim against Phelps. I think that could be, we could probably cut both of his arms off, and he could win that race 100%
Right.
of the time.
By miles.
But that doesn't mean I don't like to swim, and it doesn't mean I couldn't save myself swimming, and it doesn't mean those things. I think these are the things that we have to do, and I think Clint Eastwood said a man has to know his limitations, and we all have limitations. But I think we also have to not limit ourselves and our reach. I think if you don't sometimes shoot for the moon, you're not going to get anywhere. You really have to have high expectations. And so I think I have a lot higher expectations of myself than others outside do. I try to be good at what I do. I go to conferences to learn, not just to teach, because at each of those things, I see incredibly bright people with bright ideas. And I frequently go up to someone and say, that's brilliant. I wish I'd thought of that. I hadn't. And I think the more we do this, the more bridges we build and the less that we blow up. And I think that's what we need to do.
And CIS has grown over the years from a single clinic in 1983 to more than 20 locations across Louisiana and creeping into Mississippi. So what do you think is ahead? How do you see this evolving over the next decade, 2 decades, even 3 decades ahead?
Sure. Again, as you've seen our mission statement, my goal was never to be the biggest. It was to be the best we could be. Mm-hmm. I just didn't want us limiting ourselves based on geography, based on anything else. Because, in today's world, you can be anywhere in the world with the internet. You can learn, you can do things that you couldn't do again in the past. Our ability to reach out and learn new things is unparalleled in history and really getting better all the time. We look at Chat GPT, we look at all these new artificial intelligence things, and I'm an old guy, but I've always thought of myself as a young doctor. I've never, ever considered myself an old doctor. I've had people say, I'm too old to learn that. I'm old enough to know I want to learn as much as I can. And I'm just not as facile, perhaps, as my son is far better at ripping through the internet than I am. That doesn't mean I don't appreciate the internet. I use it a lot. It helps me look up things. It helps me communicate with others. It helps me reach others. And I think we have to keep working like that. But I think we also have to be good citizens, Kim. I think I cannot comment enough about how I think disagreements with doctors should be handled. They should be handled not on the front page of a newspaper, but on a phone call from doctor to doctor, or a visit doctor to doctor. And, just saying, look, I know what you did. I disagree with this. This is why I disagree. And, sometimes I've had those and I did disagree. And that person was able to tell me what they did and why. And I said, that does make sense. And I've changed my mind on that. But I think that's the ability to also have a little bit humility to say, you know what? There are always two sides to every coin. And we should look at both of those sides before we judge the coin.
I do like that a lot, because still every day I have patients reporting to me that they have doctors bad mouthing other doctors, and particularly doctors bad mouthing interventionalists as not being capable of being able and shouldn't be handling peripheral artery disease cases. But with the 12,000 patients that I support across the globe in the last 5 years, we just had our 5th year anniversary this month, and literally I see amazing skill sets across all practices, and we've had amazing outcomes.
Yeah,
So
I agree. Here's the problem. A lot of people are really trying to be down on intervention. Well, there are many patients who are not candidates for surgery. They're
especially the diabetics and the chronic kidney disease
yeah,
patients.
they're too sick. They won't be considered because they're too sick. In order to have a good surgical outcome, you have to have a good surgeon. We don't have enough of those. You have to have inflow. You can almost always get that. You have to have good outflow vessels. We often don't have that frequently. And finally, if it's limb salvage, you really probably should have a good vein. Well, in my practice, critical limb ischemic patients who have all those criteria constitute about 10% of the patients I see. Those, I call those Disney World patients. Okay. The average patient I see has terrible vessels in the foot, has poor vein. They're old, they're infirm, they have these other issues. And in those cases, clearly intervention offers an option that is not available from surgery. And so again, I think it's short-sighted. It's like the surgeon whose feelings were hurt when a patient saved his leg and felt better. I mean, that should never happen. If the patient is the center of the focus, that would not happen. And so to say, well, this interventional stuff never works, such nonsense. I can show case after case after case of bypass surgeries that failed, that I've had to go in and intervene to save a limb. Does that mean that surgeries are bad? It does not. I still send cases for surgery. I do. And I think sometimes it's the better choice. That's part of the art of medicine. But to say that you should never do an intervention is foolish. It's makes no sense at all. And it's really only looking at one side of a coin and trying to judge the coin.
What we always tell the patients is, make sure if you do have a procedure, one, try to delay it as long as you can, as long as it's not limb threatening, right?
Right.
Or life threatening. But we always say, make sure to ask the doctor, what is your contingency plan when this fails? I think that's so important, because there are certain procedures, such as the axillary bifemoral bypass, which is being still performed here in the US
Yes.
far too often when there are other options available. And there is no answer. Doctor, what is the contingency plan when that fails? Well, we just have to kick the can as far forward as we can. No,
Yeah.
you need to kick it as far as you can to where when that fails, there is another option.
Sure. And that's it, and sometimes too, when surgery is performed, vessels are actually tied off. They're ligated, and that also burns some bridges. That is sometimes a problem. And sometimes interventions also can burn bridges if people put stents where they shouldn't be. Again, that's why we have to teach more. That's why we have to have more meetings. But, the good news here is the following. Whoever says interventions are inappropriate and surgery is always perfect is not paying attention to a wide body of published literature. I would refer one to a graft of Goodney. And Goodney has shown that over the years, as surgery has decreased And as interventions have gone up, less amputations are being performed. Now, the logic there for anyone who's willing to open their eyes and look at it is that intervention has to be good. Because if it was bad, more people would be losing their legs, not less. And if surgery was the only answer, more people should be losing their legs, not less. This is very, very clear logic. And yet there are many who don't want to see that logic. That bothers me. And I think it makes no sense. And, do we have to improve interventions? Of course we do. And there are wide discrepancies from site to site with interventions. And you know why that is? It's a relatively new technology. The technology that's been used for surgery is old. It's 60 or 70 years old, that people have been perfecting the surgical procedures. Many of these newer techniques are 5 or 10 years old, and people are still learning them. They're not at that point. Unfortunately, right now, we don't have a referral system that's appropriate. When a person tries and fails, they're often not said there might be somebody who could help you, beyond this point. And I get a lot of patients like that, and it's resulted in good things. But a lot of docs won't send to another doctor if they fail. That's silly again. I mean, I think we have to do this. And if we're just good citizens and do the right things, I think we could really improve the outcomes in peripheral disease.
Yeah, if you're going to give up on a patient, give up the patient.
Yeah.
Give that second set of eyes on them, give the patient the best chance, right?
Yes.
At getting their legs saved and remaining on 2 feet, which will increase their lifespan as well. I just have 2 more serious questions, and I just have a few fun ones. And
Sure.
we'll like get on with your evening. We really appreciate your time, but I do want to talk about just a couple of the really cool developments ahead in the treatment of advanced PAD, and how you see some of these developments reducing the need for repeated interventions. And one of those, I had just had the opportunity to go down and visit their headquarters down in Southern California at Reflow Medical with
Right.
the spur technology. And I'm
Right.
curious your thoughts on that particular technology,
Sure.
both being used in the legs as well as ultimately in the heart.
Sure. I think the spur technology is a very interesting technology. It's really harnessing several things. Number one, the spur. So this is a device which expands like a balloon, but it's metal. It's like a stent in a sense as well, and it has sharp needles that we call them spurs, but it's little needles that stick out and they enter into the vessel wall. Now that's going to allow us to deliver drug into the vessel wall versus just applying it on the outside of the vessel wall, on the inside of the vessel, but not deep into the vessel itself. But also these multiple little spears serve as focal force concentrators, allowing the vessel to be more effectively opened. So we've long known with intervention that the bigger channel we can make, the better. If we can lessen with drug uptake the chance of injury, limiting the outcomes, that gives a better result. And then finally, that there are certain things that a patient must do for himself, like not smoking, like taking antiplatelet drugs, and that can make a difference. And so I'm very bullish on the spur. I'm also bullish on some of the research looking now, showing that if we achieve better platelet inhibition, greater than 30% platelet inhibition, that we can lessen restenosis dramatically. There have been a couple of articles, the group with Anahita Dua have published some of this. I find this remarkable data, and I think that there's a lot that we can do here because, again, guidelines, which are kind of agreements between doctors, but aren't always based on pure science. When we speak of antiplatelets in those guidelines, they typically use the words aspirin and clopidogrel. Well, we also have other antiplatelets that really are often more effective. We know that 30% of people are Plavix non-responders, up to 30%. That's been reported, yet that's guideline. That's the one they speak of in terms of the ADP receptor blockers. There's a drug, prasugrel, that work that doesn't have the problem of being a non-responder. Ticagrelor, another antiplatelet, doesn't seem to have that. Rivaroxaban, which is an anticoagulant, it's a 10A inhibitor that blocks the conversion of prothrombin into thrombin by affecting thrombin levels. That's also a platelet inhibitor because thrombin is one of the strongest stimulators of platelet activity via the POR1 receptor. So it's all of these things. It's the immediate result that we get. It is the drug we deliver that works. It's how patients take care of themselves. And then finally, how we take care of the patient after, how we follow them, how we make sure that, that all those things medicinally that we can do are in place. And I think putting all of those issues together is how we're going to solve the problem of restenosis, because by and large, we have pretty much solved the problem of crossing. In the vast majority of good centers, we can cross most occlusions. In the vast majority of centers, we can open those occlusions. The next big problem we have is keeping them open long-term, making sure a patient is one and done. We're not there yet, but we're getting closer all the time.
And I love that you bring up the role of the patient in this general holistic approach, the conservative approach to PAD, because I know we've talked a lot about procedures, and that's where a lot of doctors face the scrutiny. And so I know we've focused a lot of that here in this interview. Because you have made such great advances. Most of the patients you deal with are those patients that have been told amputation, and you're trying to prevent that amputation. But I'm glad that you have brought us back to the medicinal therapy, the pharmaceutical therapy. You've brought us back to the patient's responsibility, the smoking cessation, the walking, the dietary changes. And I'd love for you to, because I know several of my patients have come your way, and your team has had such powerful conversations with these patients to say, this is your responsibility. So pretend I'm a patient. How do you talk to me as a patient to say, you know what, you got to walk, walk, walk? Why do I need to walk, walk, walk?
Sure. So our first thing that we tell our patients is that you have a life-threatening disease. It's affecting more than just your legs. And we're going to do all that we can to get blood flow to the legs. But the long-term outcome is going to also depend on you. Okay. We know certain things to be very important. We must control your cholesterol. You must quit smoking, not decrease, quit, because any cigarette smoke increases the likelihood of clot and spasm. And so you must quit. You must walk. And the reason that we walk is as we walk, if there's any element of the blood, of not getting enough blood to the leg, our body goes into a process that we call angiogenesis, where it helps to build collateral blood vessels to the legs. And so often if a patient just simply has pain in the legs when they walk, pain in the muscles, if we can have that patient walk a lot, they actually improve the blood supply to their legs. And that can be all the therapy that's needed. And we often try that first. In fact, we usually try that first in people who just have claudication or pain in the muscles when they walk. However, if they have critical limb ischemia, that's a different animal. We don't start with a walking program. We clearly tell these patients once we get blood flow, we want them walking. But right at first, particularly if they have ulcers that are non-healing or gangrenous changes of the skin, the trauma of walking may be somewhat harmful to that patient and healing that initial issue. But we tell patients that we're a team, and part of that team is them too. It's all the healthcare providers that we're putting in, but that their role is very important. They have to not just go to the drugstore and get their medicines, they have to take them. That it does no good to say they have the medicines and not take them, that they must quit smoking, that they really need to follow all of these other areas. And we really get a lot of buy-in. You know, national statistics talk about 20% smoking cessation. We're somewhere near 80% in our conversations with these patients of getting them to quit smoking and through this initial area. I think, you know, unfortunately, it takes extra time. But fortunately, we're willing to do that right now. And I think it's a very, very important part of patient care. One of our basic tenements of our mission statement was communication by word and deed. And, patients don't go to medical school. Many don't read, the latest articles. They don't see that. And all too often, they're spoken to with words they don't understand. Just as soon be showing them hieroglyphics and ask them to read it. It's not that. What we have to do is we have to be able to truly effectively communicate. And I think it's one of the lost arts of medicine is we've transitioned more and more to pure science. We have lost some of the art of medicine. The older doctors took the time to sit there and talk with the patient. They made house calls. They did things where there was touch. But that doctor couldn't pull a CT out of his pocket and make a diagnosis. That doctor couldn't get an MR at that patient's home. That doctor couldn't do an EKG at that patient's home. Yes, we've advanced tremendously scientifically, but in terms of psychologically how we deal with people, which is also very important in touching patients and making them have faith in us, we've probably gone the wrong way. And I really work hard to try to effectively bond with my patients, to make sure that they understand I'm working to try to help them, that I'm going to do everything I can, and that I do care about their outcome. And I think when you do that, you form a great bond. I have been blessed through my career of having great bonds with my patients, and I would never change that.
Do you have that one patient where you said to yourself, oh my gosh, the Cardiovascular Institute of the South model is working? Like, we've got something here.
Truthfully, Kimberly, I've had thousands, but I will tell you one lady who I just remember like yesterday. She was a near and dear patient to me, but I met her. She was brought in to me by her son. She was in a wheelchair, and she was an African-American lady. Her sons had been LSU football players. Her Man Mountain boys, and she was dejected, crying in her chair, couldn't walk, in pain. She had a non-healing ulcer on her foot, and she'd been told a major amputation was her only option. She says, "Doc, baby, can you help me?" That was her whole comment, just like this. And I said, "Miss Fern, we'll certainly try." And so we brought her in, and we performed an intervention. And I was out. After that, I had a conference in China. I was out for about a month. Well, I came back in, and she walked in the clinic. And I walked in the room. She said, "Come here and give me a hug." That was the first thing that she told me, which of course I did. And I said, "Well, how are you feeling, Miss Fern?" And she stood up, and I videoed this. And if you want, I'll share this with you, because she told me, "Show this to everybody, Doc. I want them to see what can happen when you fix a leg." I said, "Miss Fern, how are you feeling?" And she says, "On two," and she starts dancing. "Hey, Miss Fern, tell me how you feeling." That leg's better, huh?
Hard two.
Okay. Oh, that's great. Okay, now, this is a woman brought in a wheelchair. Unfortunately, 2 years ago, she died of COVID, not because she lost her leg, not because of other things, but she had 8 or so years of being able to walk, being happy. And every time that I saw her in follow-up, first thing that happened, I got my hug. People like that, we have so many like that. We have, I'm not, people say, "Well, you probably are showing the one case that you've had a good result." That's not true. Before I left for this most recent conference with the hurricane coming, I had 10 limb salvage cases that day. Every one of those patients had a pulse at the end. That's where we've come with limb salvage as compared to where we used to be. We could have never done that before. And it's a lot of effort, it's a lot of time, but each of those patients absolutely appreciates when you've done this. I mean, there's no two ways about it. And so I have many, many of those memories. I will never destroy my video of Miss Fern dancing for me after we had fixed her leg. Things like that, that's the real payoff for a physician. To be honest, that's the reward. And that's why we do what we do. And, that's what so angers me when I see newspaper articles, speaking about all the evils and the bads that people are doing, and never criticizing people who take the shortcuts. Let's just amputate. People who don't do everything that they can. And I find that disheartening.
And I think the lesson in that is very clear. Don't even need to say it. And so, is there a case though that had you scratching your head sometimes? You mentioned earlier in the interview, and I wanted to bring this up back then, but then we got into another tangent. We have so many different ways we could go with this. There's so much you have to say. But is there a case that had you scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently? I mean, a patient that, there are all these unnecessary, yes, they might have back issues, but it might not be the degenerative discs that are causing the actual leg pain. So why are you doing spinal fusions or whatever it might be? Can you share a case that we can all learn from, of a patient whom should have been diagnosed sooner rather than later?
Yeah, obviously you have to feel pulses, and a lot of times that's not done. And sometimes patients do have back pain, and back pain and arterial pain from an iliac disease can be very, very similar. And this patient already had he'd had a back operation, but when he saw the orthopedist, they were thinking they needed to revise an orthopedic procedure on his back. But they'd sent him to me for clearance. And so I was doing the routine physical exam and going through things, and he had physical findings of severe leg ischemia, and he had absent femoral pulses, totally absent. So we got a CT, and his aorta and both iliacs were totally occluded. Okay, and he actually, then when I looked at his feet, he had a small ulcer under his foot as well. So I called the orthopedist and I said, I think we've maybe found another cause for his leg pain right now. And I think certainly I'd be frightened to operate on his back right now with the aorta and both iliacs occluded. I think that could be problematic. And so he said, yes, why don't you fix that? We did. And his back pain, of course, went away. Now, I'm bringing that up, not even because I fault that doctor. He's not looking at the pulses, routinely. These diseases can be very, very similar. In fact, one of the differentiators that we use between it coming from your back or coming from vessels is walking. Okay, and what do I mean by that? Well, if it's coming from the back, often if someone walks, for instance, holding a grocery cart or walking with a walker, they don't have the pain because they're supporting the back. But if they walk, and anytime they walk, the legs hurt, it's usually vascular. Otherwise, it doesn't matter if they're leaning on something because the muscles aren't getting enough blood. That's one. But, in terms of speaking about patients where I learned a whole lot, I had one man that came to me and he had had 5 surgical procedures on one leg. He had horrible gangrenous changes. He had osteomyelitis of his great toe, which I could see by picking up a little flap of skin on his toe that was already there. He says, "Doc, do you think you can help me?" And I did Doppler on him, and I had no arterial or venous Dopplers. I looked at the CT and the MR studies that had been performed, and these were world-class hospitals where this man had been worked on. And there were twigs of vessels below the knee that they had seen. They had never, ever seen the perineal vessel, which usually, if it's there, you see, But in this man, it just didn't show, but it was there. And this man begged me to intervene on him. And I said, I just don't think I can help you. By all things that I see, your foot is unsalvageable. He says, "Doc, please try." And I said, "But I'm fearful I will hurt you." And he says, "Doc, not like I plan to hurt myself if you can't help." And very clearly, he told me he had bought a gun and he planned to blow his brains out if I told him I couldn't help him. He told me that. He was dead serious with me. He had already lost his other leg in an amputation. And he says, "Please try." So I got him to sign a very convoluted consent form. And I told him, I said, look, the insurers will not cover this. I'm quite certain of that. And, that he was pushing for this. As it turns out, I did the procedure. I found that hibernating perineal artery. This man was able to, we got blood to his foot. He had a transmetatarsal amputation and skin grafting. And 13 years later, he still had his leg. And that was one procedure. Well, it's more than one procedure if you take the skin grafting and the other things, but one procedure. And we found a vessel that showed up no other way. Now, what did I learn from that? I learned that our absolute knowledge is not absolute. That I should have seen those vessels by CT. I should have seen them by MR. And those weren't performed at my institution. Those were performed at some of the most well-known institutions in the world. They were performed by good people. And the Doppler study, they also had not seen any flow. How can I explain that? I can't. So it was perplexing, but it opened up my eyes. Sometimes there are things that go beyond our ability to understand. Since then, I've worked on many things to see if can we better delineate patients like that. And we're getting a clue here or there, some things that might change. But medicine is a journey. I've said that before. It's a journey. There are surprises along the way. There are heartaches. There are heartbreaks sometimes along the way. But the sum total should always be positive, especially if we do the right things. And one of the keys is not letting it get to that point. Again, we talk about all the great interventions that we have and stuff, but I wonder if we lived in the perfect world where we took these people with risk factors and we erased those risk factors early on. What could we do? And that's really what we have to strive to get to.
So finally, share those 6 minutes that mattered in your career, that defining moment that shaped who you are today and what you are doing with your career. What were those 6 minutes that truly mattered?
Sure. I mentioned several of those. Certainly the man whose leg we saved, and I had to defend myself before a committee of ethics. And that helped me to understand that, we really have to communicate and certainly list things as we do this. But I am convinced I did the right thing. In fact, I think any rational human being is there. That was very important for me. And it solidified my ability to take certain chances, certain times, if I thought the chance was a far better option than the alternatives. Certainly, this case that I've just mentioned, where my absolute teaching had told me what was going to happen, and it was absolutely wrong, and that we ended up with a great result. Certainly the man who lost his leg when I could not, when I was not allowed to treat an iliac that I knew had to be stenotic, that would have been a simple balloon procedure and this man would have never lost his leg. That was a defining moment. But more defining moments was as I started to look at the literature and realize how many people are given as their first option an amputation without a vascular consultation, without an angiogram, without an ultrasound. And I started to say, how on earth can we as an advanced nation do this? And this, by the way, is happening all over the world, still is happening in the United States of America. I cannot fathom that is okay. Cannot fathom that. We are not yet able to save every single limb, but we absolutely know, and we have reams of data, that getting an angiogram before an amputation saves limbs, because many of those actually have easy options. So there have been many defining points, many things that I've seen throughout my career. Certainly some of the more recent articles, which have stopped people from using atherectomy, stopped people from using IVUS, even though there are reams of data showing that IVUS is helpful. Those have further shaped me. In fact, have made me a little belligerent, frankly, in how I approach studies like Best CLI, which I thought was a terrible study that came to very poor conclusions. The New England Journal of Medicine did take my letter to the editor, did publish it, where we, brought out the criticisms of that. I told him, let's wait and see what happens with the Basel II trial. In the Basel II trial, completely had an opposite conclusion because that trial was biased. So there have been many things that have shaped my opinions, but I am trying to be balanced. I try to look at both sides of the equation. I'm hoping that not just me, but each of my colleagues and that others make a point of looking at both sides of a coin and assessing all things, and then saying, what is our best option here? And you know what? That may be different for different people. There may be a surgeon with such fantastic skills that his bypasses always work and they never go down. There may be an interventionist who never fails and it always gets the perfect example, the perfect outcome. And that's the art. Just like you could give me all the same paints, all the same oils, all the same canvas used by Monet or other people, I wouldn't have the same result. Even with the same tools, even with the same diagnosis, even with the same dreams. And so I think that's the art of medicine. I think we have to quit criticizing the art of medicine as we go on. Certainly, there is no room for people doing anything unethical. Certainly, there's no room for taking advantage of patients, but there has to be room for differing opinions.
Yeah.
And when we try to quash,
it's still a practice.
when we try to quash those, it's an error, and that's how we'll stop progress.
I agree. And I am getting pinged by several people in the live studio audience. Heinz, go ahead and unmute and ask Dr. Walker your question.
Hi, doctor. So I have a blocked artery in my SFA, right SFA, and behind the pop. And they put a superior stent in my SFA. They cleaned out the pop artery. What did you find from your experience, the success rate on that superior stent in the pop artery? Since before that, it was always not feasible to put a stent in the pop artery.
Sure. It's a great question. So the reason that the popliteal artery, there are many reasons why historically people call that a no stent zone, was because the artery bends a lot there as you bend your knee, and most stents could not bend that way without potentially fracturing. Secondly, the popliteal site is a site that frequently is used to bypass with a femoral popliteal bypass, and so that's another reason. Thirdly, the popliteal artery was historically often quite calcified, and most stents would be compressed in those very calcific lesions. My experience with superior stent behind the knee has been superlative, to be honest with you, but superlative when it was placed correctly. For the superior stent, it is an interactive stent. By that I mean it's a wire interwoven nitinol stent. And so as we place it, it is very important to first make sure we very aggressively open the vessel with balloon angioplasty or prepare the vessel, or else the stent will come out elongated. By that, I mean a stent that's designed to be 15 centimeters long might end up becoming 20 centimeters long. Now, if the stent comes out elongated, then the outcomes are not so good. Now, that stent can also be compressed. We can take that 15 centimeter stent and make it 10 centimeters or less. And when would we do that? We would do that sometimes purposefully. If we had a very hard lesion that was trying to compress the stent, so it would give it more force at that point. There is no major penalty long-term for a shortened stent because you're just putting the metal there and the strength is very strong and it's still very flexible. If we elongate the stent, long-term outcomes are not as good. But when that stent is placed properly, when it is not elongated, when the vessel has been prepped, patency rates have been very good, even with very long lesions. And I think it's probably the best in class stent behind the knee.
Thanks. Appreciate that.
Thank you. And one more. We have time for just Nancy, go ahead and unmute and ask Dr. Walker your question.
Okay.
Hi, doctor. Congratulations to you. I love your philosophy on prevention. I recently found out that I have very high lipoprotein A. I have volunteered to go into a trial with Eli Lilly, and I get my first dose next week. What do you think about revascularizing the blood of patients with very high LPA levels. I'm fighting hard, been fighting hard for over 20 years, and just wondering what your thoughts are on that.
Sure. We have some medicinal therapies that can help with LP(a) elevations. I, by the way, have LP(a) elevations. And so it is something that is important. There's recently been some very interesting research some of this is not yet even in print, but via personal conversations that I've had with fatty acids, some of the fatty acids as well, and some of their lipogenic factors. So I would tell you that we do have medicines that can affect LP(a), that you can get. You can speak with your doctor about that, because some of those, there are many that work. There are several, I should say, that work there that can affect this, but they have to make sure it's right for you. That it fits within the things that you're doing. But I think addressing LP(a) is one of those many risk factors. By the way, that does affect peripheral artery disease. It does affect coronary artery disease. And so, it causes atherosclerosis, or it's been associated with higher risk of atherosclerosis. And perhaps we can improve that. We know that with certain medicines, we can improve it in mice. That part I can tell you for sure we know. And that's some of the research that I've told you that I've been speaking with some people in North Carolina about. They're doing the research, not I, but they've reached out to me to communicate. And I'm very curious to read and learn more about this. I'm still a bit of a novice on it, but we'll get there.
Right. I'm taking Repatha, so I am already at, and hopefully I'm not going to get the placebo. Hopefully I'll get the actual medicine. So
yeah, well,
by Lilly. So
yeah, well, Repatha is a spectacular drug too. So it's one of the great drugs for this.
Yes. Good. Thank you. Thank
you.
you.
Nice talking with you. Yes.
Fantastic. Thank you so much, Dr. Walker. We just really appreciate you so much. A big congratulations to you and your team at the Cardiovascular Institute of the South, our Global PAD Impact Award winner for the Global Limb Salvage Team of the Year. I'd like to give you a moment just to give a big shout out to your team. I mean, and the legacy continuing forward.
I will tell you, I've been blessed with the partners that I have. I've had people who shared a vision that I had initially created, and they've really taken that vision further than I could have personally taken it. These guys work tirelessly. You've seen them doing live cases for conferences around the world. They work night and day. It's not just the doctors, it's the nurses, it's the cath lab techs, it's the receptionists. We have a culture of caring that has occurred. And I'm so proud of this group of people. I cannot tell you how many employees we have that have been with us more than 30 years. And so this has become more than a job, it's a devotion. It is really something that they've done. I'm so incredibly proud of our group. These guys are world-class. They work hard, and they've certainly made me a lot better doctor.
Well, congratulations again, Dr. Craig Walker and the entire team at the Cardiovascular Institute of the South in Louisiana and Mississippi, with an impact all over the world. We appreciate all you're doing to save life and limb.
Thank you very much.
Thank you.